Teşekkür ederim başkan. Bu üç güzel...
Thank you very much, Mr. Chair. After these three beautiful presentations, I will try to say a couple of words about treatment resistance, but each speaker touched upon this issue briefly. And Dr. Dimelis, of course, made a very scientific presentation and humorous at the same time. Thank you very much, and you've made my job easier, I have to say, Dr. Dimelis. This is the last presentation. I'm sure you're all tired. I will try to finish my presentation as quickly as possible so that you have time to take a break and rest after this session.
Türkçe alabilir miyiz buraya?
Can we have the Turkish version of the slides on one of the screens at least? Okay. Recently, something happened in Istanbul that would also concern our neighbor Greece as well. It was an opening. It was an opening ceremony. There were many different projects that were implemented back in the times of the Ottomans as well. And here, for example, you see a design from the Ottoman times. This was the first bridge on the Bosphorus designed by the Ottomans. Another crazy project was called Jisr-i Bubi. This is actually an undersea tube. It has been realized recently, Marmaray. This is one of those projects that will seamlessly connect Europe to Asia. You might ask me what this has to do with our deceased. Our disease used to be called manyak-ı cinneti itinatiye. In Ottoman terms, that is. What we're trying to do is, in other words, with those old words, this is a disease with craziness, and this is what we try to reach balance. But sometimes, in spite of all the struggle, we cannot strike a balance. My presentation will cover all these topics that you see on the screen. It will start off with the distribution of symptoms, resistance, and finally psychosocial interventions and conclusions and suggestions. This is a slide that I'm sure you're very much familiar with. Bipolar disorder patients spend half of their lives with symptoms and 2/3 of their lives in the depressive phase. This slide actually explains why there are more studies studying the depressive state of the bipolar disorder. What are the treatment objectives? Symptom control and recovery from acute episode. This is our main target. We want to end the suffering of the patient as quickly as possible and as efficiently as possible. Relapse prevention is another target, and recovery of functionality is another target, because functionality as of now is very important for all human beings. Symptom improvement is not enough on its own. Residual symptoms, for example, are very important in terms of functionality. Minimum cognitive deterioration is what we want to achieve, and prevention of illness advancement. This is another objective that can only be achieved through controlled therapy. Otherwise, every episode breeds another episode. How are we going to manage all these targets? We have many pharmacological agents, and we try to combine them to come up with the best alternative for that specific patient. It is very difficult actually to define bipolar disorder because it's usually recurrent. There's a tendency to shift. Therefore, you cannot really define resistance, and you know that the clinical appearance of the disease changes with time. It might either become atypical or else. So we might end up with a different case. So there is no consensus when it comes to the definition of bipolar disorder. Naturalistic trials say that 1/3 of bipolar disorder patients do not respond to therapy, but we don't have any concrete data. We have to define the phase very well. I mean, in order to call a disease resistant or refractory, we have to first of all define the phase. Is it an acute phase? Is it acute mania, acute depression, or induced mania? Or are there some other qualities that are present in the case? We also have to define therapy and insufficient therapy. What has been conducted so far? What did the patient respond to or not? We have to answer all these questions so that we can clearly diagnose treatment resistance. Has the minimum threshold dose been used or not? Or is there a case of intolerance, for example? Intolerance is not a case of resistance. And this turns out to be a very confusing factor for many doctors. We have to definitely decide whether the patient at that time, at that moment, is on antidepressants or not. Sometimes this might be forgotten. Haluk always gives this example, actually, saying that the patient does not respond to therapy, and after a while they discover that the patient has been on an antidepressant for a very long time. And there are many different scales that we use to define response. And for some cases, of course, we need combination therapy. Of course, those patients that do not adhere to therapy cannot be called treatment-resistant patients either. That's another group. Well, but we still have something to say about treatment resistance, of course. What causes treatment resistance in bipolar disorder? Does it have to do with the nature of the disease? For example, is there a group of patients that will not improve whatever we do? Does this have to do with the nature of the disease? Or can all patients improve, but we have not yet developed the right modality of treatment? But this is where we are now, and we have no projections into the future. So as of today, we have to know the period type. Mixed periods are a bit more resistant than depression. Rapid cycle is a resistance factor. Alcohol or drug abuse is a resistance factor. And other comorbid diseases also present as resistance factors. In terms of comorbidity, we did not match the figures of United States or Europe before, but now we do. Personality disorder, a comorbid personality disorder, is another significant reason for treatment resistance, and some other social factors have an impact on treatment resistance. As we interview the patients, we have to look into some possible psychosocial reasons as well. But who is resistant, by the way? Is it the disease that is resistant? Is it the patient, or is it the physician? I asked this question before. Does it have to do with the nature of the disease? Yes, a subgroup of patients are resistant by nature, but there are also some patients who do not fully comply with the therapy. Therefore, they might be labeled as resistance or refractory cases. And side effects also come into being in some cases, which lead us to think that the case is a resistant case, but it's pseudo-resistance. How about the physicians? The correct diagnosis is very important, as well as proper treatment and adequate time for treatment. Sometimes clinicians call a case resistant without going through or without meeting all these criteria. Side effects can be very challenging for some patients, but at the same time, they might lead to lower adherence or compliance with the therapy. But in our clinical practice, there are some cases in which we could use the side effects for the favor of the patient, not as you see in the cartoon, of course. About the acute episode, there's no consensus. The information we already have about the acute episode has been borrowed from depression therapy. If we were to define it, we could say that it is the inability to get response despite use of at least two medicines, two drugs, although used at effective dose and adequate period. This is a better definition for depression. So maybe in bipolar we shouldn't say two drugs or two agents, but we should say two therapies. The previous speaker, Dr. Dimelis, also referred to this. Two strategies actually is almost a rule in bipolar disorder. According to the Stanley Foundation data, patients are on the average on 4 drugs. In the rapid cycle patients, the patients are on 4.6 drugs, whereas the non-rapid cycle patients are on 3.5 drugs on the average. We're all clinicians, and we see patients every day in our clinical environment. Therefore, we know how many drugs they're on. There are some criteria that have been introduced to call a case resistant. You have to continue with therapy for 6 weeks in mania, 12 weeks in depression, and 12 months of maintenance, and not get any response to call the patient resistant to therapy. But the mirror phenomena also seems to be a correct method. According to DSM-5, there's no longer a mixed episode. But now we're talking about episodes with mixed qualities, either in the manic or the depressive phases. These periods are periods that we have to take into account. Some people call mania and the mixed episodes the same. Some people call them different. There used to be a difference in the definition, but now in DSM-5 there's a separate definition to call an episode a mixed episode. We knew that in the mixed episode cases there was a high resistance, and we will probably continue using the same definition. If there are some attributes from the opposite polar, then we will probably see more resistance. I already referred to alcohol or drug abuse comorbidity. I want to highlight this comorbidity specifically because it brings about some additional negative impacts, such as suicidal ideation, hospitalization, rapid cycling, and some mixed attributes or qualities. And of course it leads to a worse prognosis. So what shall we do in terms of treatment strategies? First of all, we have to review the therapy. In other words, we have to check whether we have administered the drug at an adequate dose for a proper amount of time. And we have to review the history of the patient to see what strategy has been effective and what hasn't been effective so far. And we have to revise our diagnosis based on comorbidity, psychosocial factors, and some other factors as well. Later on, of course, we have to sequentially prioritize the strategies and go and implement them one by one. Of course, in severe and risky cases, ECT is always an option. In slight and medium cases, we have to take into account mood stabilizers or combinations. Clozapine is definitely an option to consider, and there are some other options that I will refer to in a couple of minutes. This is quite a new review. Let me go through them through it very rapidly. Clozapine, olanzapine, donepezil, and some other form of clozapine were compared in this study. Clozapine and olanzapine, we know that they're good, but donepezil was also studied in some other study, and they all yielded positive results. Resistant or refractory bipolar depression. Let me say a couple of words about this as well. Of course, we need a certain treatment period, which is 12 weeks. We have to take into account the possibility of suicide. in these patients. There has to be suicidal ideation, for example. The sultans maybe did not suicide, but in bipolar depression, we know that 15% of the cases end in successful suicide attempts, and 50% at least attempt suicide. There's some confusion in definitions as well. Sachs and Yatham, for example, have different definitions. These are very well-known researchers of our time, and there's no consensus among them. We have to follow the prioritized strategies one by one in these cases as well. In severe and suicidal cases, ECT should be considered, and in slight or medium cases, we might consider lamotrigine, TSA, SNRI, or some other options. We, as physicians, have to put an end to the patient's suffering. Therefore, we have to find a way. I referred to a review before. Let's have a look at the studies in this review again to do with depression. There are some positive, there's some studies that yielded positive results with quetiapine. TSM and ketamine are two other agents that provide positive results. However, these results are transient. But still, agents like ketamine are promising for the future. Bupropion, pramipexole, aripiprazole, and ECT are some other strategies that were tried and that gave positive results. If these do not work, we have to move on to some add-on strategies. These are experimental strategies, of course. A review was published recently. This review only brought together randomized clinical trials where they studied bipolar depression 1 or 2. They chose studies with at least 10 cases, and they chose studies where there was no response to one DDD2 therapy line. Goldberg, for example, studied pramipexole and got some positive results. Nuremberg had achieved a pronounced effect with lamotrigine. There are some positive studies with ketamine as well. However, ketamine, unfortunately, has a transient effect. ECT, on the other hand, is a treatment tool that we all very well know. So if there is such an option, or if there is indication, I think we have to consider ECT as an option. Otherwise, I think it would be malpractice not to consider ECT. What are the experimental options? Pramipexole, riluzole, ketamine. These are some of the experimental options. This is a study from Turkey with pramipexole. 2 resistant cases responded to pramipexole, and they reached remission with these patients. This study was published 4 years ago. We talked about somatic therapies before. ECD, vagal nerve stimulation, and TMS are some positive methods, but for TMS there are 2 results. One is negative and one positive. Okay, what we're trying to achieve as a result of all these strategies is to strike a balance. No matter which tools we prefer, what we try to do is to reach a balance. And no matter how hard we try, no matter what we do not always get the result that we want. Sometimes the tools that we have at hand are not enough, and we can't always end the suffering of the patient. Let me say a couple of words about the maintenance periods as well. What we do is a switch, an add-on, or an augmentation. So actually we're trying to cook the best meal with the ingredients we have at hand. If the patient likes the meal and kicks out of the episode, then our treatment will be a success story. The 12-month period, as I said before, for maintenance is not an exact figure. Some researchers, for example, claim 18 months of treatment. But I think what we have to do is to check the frequency of episodes before the therapy started. And I think we have to talk about no response to two mood stabilizing strategies at adequate dosage and sufficient length of time. There's quite an uncertainty, of course, but I think it's very useful to use a life chart because sometimes we miss certain facts about the patient, so I think it's very useful to make use of a life chart. And partial response is still a question mark. Shall we consider partial response as a resistance to therapy or not? Once again, we have to see whether it's a case of pseudo-resistance. We have to check the history of the patient, revise our diagnosis, and go through all the strategies one by one, just like we do in the acute phase. A couple of words about clozapine. This is a 48-month study. There seems to be a very strong response to clozapine. So clozapine is an option to keep in mind, and it's in the guidelines as well. This is another review for resistance to maintenance. ECT, olanzapine, ECT and add-on olanzapine seems to be, for example, an option. A study from Turkey was published on this as well. This study was on 8 cases resistant to standard therapies. The patients were given 200 to 350 milligrams of lamotrigine, and the patients were followed up for quite a long period, that is 37 weeks, and 6 patients were reported to improve. This is a study back from the year 2000. A couple of words about maintenance ECT. If we have no other options, then maintenance ECT is one of those options to try. I know that Haluk has a very large series of 40 patients. Even at Bakırköy, we don't have such a large series. There are some naturalistic trials as well, retrospective ones, prospective ones, and case reports. However, methodologically, I cannot say that these are very robust designs. But I can at least say that the outcomes are effective and reliable. We've only talked about pharmacological options so far, but there are some psychosocial intervention possibilities as well. Family-focused therapy, family groups, CBT are some of these options. IP as SRT is another option about which there's growing number of evidence now, and group psychoeducation. These are all factors that should be added to the therapy. We know that bipolar disorder is a disease that definitely requires pharmacological intervention. However, if it's accompanied by psychosocial intervention, this will increase the success rate of treatment. It will reduce recurrence and increase the rate of remission, as well as decreasing the rate of hospitalization. In family-focused therapies, recurrence is delayed, and another study showed that hospitalization rates also decrease. So we can say that the relapse rate reduces, there's a reduction in mood fluctuation, and there's an increase in compliance to therapy. So what are the lessons that we can learn from all this data. There seems to be no consensus in the definition of resistance. Maybe in the future we will have such a definition, but it seems a bit difficult taking into account the nature of the disease. Systematic trials are still inadequate for the treatment of resistance BD. In the manic episode, the patients, the physicians actually can cope with the disease to a certain extent. But in the depressive period, they can't really cope with it, and patients spend 1/3 of their lives in the depressive phase. And we have less drugs to deal with the depressive phase, rather than the manic phase. Our diagnosis must definitely be correct, and we shouldn't delay the diagnosis. There are some studies, for example, that point to a delay of 8 to 10 years in diagnosis. We have to investigate the causes of resistance. We have to determine efficient strategies and try new options. We have to learn at least one of the psychosocial interventions and put it to use. If we can, we have to use more than one psychosocial intervention. If the family can express their mood easily, then, for example, we can use the family in those patients, or we should avoid CBT in some of the patients. If we don't have enough funds, for example, we might prefer group psychoeducation. Group psychoeducation was found to be as effective as individual CBT in some studies, for example. We don't have that much of a finance, so group psychoeducation can be considered as well to replace CBT. So far we've been so successful at our hospital, but we still have a long way to go. We have some classical options, that is the classical antidepressants and antipsychotics. There are the best sellers, of course, such as mood stabilizers, lithium, valproate. And we have the new options. We talked about new options as well. Of course, maybe we should consider atypicals as new options as well, but the experimental ones are also within this category. We have to find the right utensil for the right patient. Otherwise, no matter how delicious the food is, it will be hard for the patient to eat and enjoy it. And we have to speak a different language with each and every patient. If the patient does not understand our language, then we have to find the right language to talk to them. We cannot force patients to understand our language. And we have to be open to new research. We definitely need new research, especially in the field of in the depression phase and in the maintenance phase. Let me finish with an offer. Our next year's Congress will be organized in Antalya again. I'm sure it's going to be a rich Congress. Just like this one. Erhan Kurt will be one of the co-chairs of the Congress, and Feyza is here too. They're the co-chairs of next year's Congress. I'm sure it's going to be a very rich Congress in terms of content. I hope to see you there in 2014 as well. Thank you for your patience.